Hello, this is Cindy Hudson. I'm the Director of Clinical Compliance with Arbor Rehabilitation. Welcome to our compliance training for the 2021 and at least a good portion of the 2022 year ahead of us. We've got a number of topics to discuss, so I do appreciate your time and attention while we go through a few issues and items that we want to cover today. So we're going to be talking about everything from clinical updates to new policies and procedures that we have and a revised incident reporting form, as well as a little bit of information about incident reporting. So that's where we're going to start today. An incident is defined as any event that is not consistent with routine patient care, which can include accidents or hazardous exposures. An incident can be considered harmful or at least potentially harmful, and it can include occurrences to residents, staff, or guests of the facility, which might be our vendors or a family member. When we're reporting an incident, you want to make sure that you verbally report that incident as soon as is possible to your FRC so we can get the ball rolling on the communication that needs to happen. You want to write a complete and detailed account of the incident. If the incident is involving a resident, you need to complete both an Arbor Rehab form as well as the facility incident reporting form. If the incident involves only an Arbor Rehabilitation employee, only an Arbor Rehab report needs to be completed. And again, if the incident involves a patient, you need to create an addendum note in NetHealth, which is our EMR, which is going to state that you'll see an incident report, and that'll help us cross-reference that information. When you want to report an incident, this is going to be, as I said, as soon as is safely possible to let your FRC be aware of the event. And certainly you need to report this information no later than the day of the incident before you leave that building. Copies of the completed incident reports are to be sent to your regional director or area manager within 24 hours of the occurrence or sooner if possible. And again, as I said, you want to make sure your FRC is aware of the incident, your regional director and area manager are aware of the incident, and also be sure to include your facility administrator in that communication chain. So what we want to report would be the names of everyone involved in the incident, the exact time and date of the incident, the location of the incident, and you want to be specific with that. For example, in patient's room, from the edge of the bed, in the dining room, from the wheelchair, be specific as to the location of the event that occurred. You want to provide a detailed description of the incident, remembering to include everything that you can recall, and be sure that you report only facts in an unbiased and in professional terminology. Okay, you're also going to want to document the safety measures that were in place immediately before and during the incident. For example, if they had the gait belt on, and perhaps where the location of the gait belt is, if that person has a PEG tube or some kind of abdominal wounds, some cardiac surgery where you'd want to be careful to place the gait belt above that level of injury or opening. You want to provide a detailed account of the equipment that's involved in the incident. So it might be a sliding board, parallel bars, those kinds of things. And you want to include any visible injuries that were noted at the time of the incident, including any redness, any bruising, any skin tears. This is a brief snapshot of at least a portion of our revised incident reporting form. So it's going to enable us to trigger some better recall of information and better documentation of what exactly is or isn't going on during the time of that incident. If an incident involves a patient, do provide a detailed account of their mentation, their cognition, both before and after the incident. You do want to include information about when nursing was notified. So for example, unit nurse Jane Smith was notified immediately following the incident by PTA John Doe. Do not move a patient before nursing has completed their assessment. And I'll repeat that because it is so important. Do not move the person until the nurses have completed their assessment. I know that can be difficult sometimes. Try to encourage that person to stay calm, stay still. They need to stay put until nursing has had a chance to check them out. And do not leave a person unattended immediately following an incident. So use a call light, use the phone. If you can't get attention of anybody in the hallway, use the resources you might have available to get some help as you need to. Moving along, we're going to talk about transferring the plan of care for best clinical practice. If the evaluating therapist or the supervising therapist will not be responsible for the overall care and supervision of the patient, for example, if a therapist is resigning or we have PRN help over the weekends, the plan of care needs to be transferred. So per the Ohio Physical Therapy Regulations, if for any reason the evaluating physical therapist will no longer be able to provide and supervise the physical therapy care, that physical therapist must transfer that patient to another physical therapist. And the rules go on to say that this includes the situation where a physical therapist is providing temporary coverage, and termination of care does not include a physical therapist taking regularly scheduled days off or job sharing. So if you'd like to know a little bit more information about the specifics related to this regulation, there's the website listed there. It's under the physical therapy FAQs. For Ohio occupational therapists, per the Ohio OT board, if evaluating occupational therapist will no longer be able to provide and supervise occupational therapy care, the client must be transferred to another OT. And again, this information is shown in the hyperlink listed here. If you're viewing this electronically, you can go to the OT FAQs for the state of Ohio. In general, at this point in time, to protect everybody's license, we're going to talk about transferring plan of care responsibility. And this includes our speech language pathologist, because I think that not all SLPs are going to view, for example, dysphagia interventions the same way. May not all have the same approach. So if a different speech therapist does the evaluation, you may need to then designate that you are no longer going to be following that person. And then as the following clinician, you would have that option to do a recert. And this is true for all disciplines if you would want to revise any of those plan of care goals. But otherwise, for all disciplines, the therapist who will no longer be supervising that patient's care will need to document in the treatment note associated with that eval visit or that treatment visit that this therapist will no longer be supervising this patient's POC. Supervision of this POC is being transferred to Mary Smith, if you know the individual's name, or you might need to document supervision of this POC is being transferred to the designated Arbor Rehabilitation Therapist, if you do not know exactly who's going to be the following therapist. Talking a little bit more about licensure laws, we do have all of the various states' licensure board regulations posted here, the links to those areas for Ohio, Pennsylvania, West Virginia, and Missouri. I will say that for the state of Ohio, for OT and PT, they did not make material changes for the 2021 year to the licensure regulations. Other states, you may want to carefully look over your regulations to be sure that you're in full compliance with any updates they may have made. We're going to talk for a few minutes now about clinical program resources. And if you go to the Arbor website, www.arborrehab.com, go under the employee portal. You need to register for it first if you haven't already. Under the employee portal, on the left-hand column, you're going to see Arbor Clinical Program Resources. And as you scroll down, you're going to see that this is a collection of information designed to promote comprehensive care to our patients. So this is a host of information. When you click on any one of these hyperlinks on the Allen Cognitive Disability module, cardiopulmonary care, continence management, falls prevention, modalities, skilled maintenance programs, wheelchair seating and positioning, or behavioral health, any one of those areas you can click on to get a host of information about those various topics that might help you fortify the care that you're already providing. And in talking about our programs and service delivery, we do want to promote our diversity of clinical programs so that we can promote thinking outside the box with our treatment techniques. It's going to promote thorough documentation of the impairments, the treatment techniques, the outcomes. Again, there's a lot of skilled ideas for interventions. There's different measurement strategies, and we can be very objective and evidence-based with the information that we're providing when you visit and utilize those clinical program resources. It's going to help education of patients, family, and staff. Again, a lot of that information has already been provided within those documents. It's going to help patient participation and help provide that oh so important patient-centered care. Because if an individual says, I want to breathe easier, we can look under cardiopulmonary, focus on the pulmonary training strategies, and come up with some breathing techniques that might benefit our client or our patient and enable them to realize the goals that they would like to achieve, not just our functional goals, but the goals that they would like to achieve as well. So I do want to give a shout out at this moment that if you have treatment approaches or ideas or special certifications or training that you'd like to share, you have some information, we would welcome that. Please contact me again, Cindy Hudson, and let me know of the resources that you have to share, because we all learn from each other and appreciate that opportunity to promote your ideas. So in talking about our website a little bit, you saw a screenshot a moment ago. With website navigation, you want to ask your FRC for this handout if you haven't already seen it. And this is going to help you find our various forms, documentation tips and strategies, billing information, clinical information. There's a whole bunch of information, again, posted on our website. And there's a few pages of a handout to help you navigate through all the various locations on our website to realize all the resources that are available for us. So changing gears again a little bit, we're going to talk about group therapy because there's an update I want to make sure everybody is aware of in regards to our provision of group therapy now that for the most part, in the majority of our facilities, we can provide careful group therapy interventions again. So with group therapy, therapists are going to need to document why group participation might be appropriate for that individual, and that information needs to be documented in the plan of care. So when you're setting up your plan of care, you need to provide not only the billing codes that are appropriate for group therapy per your discipline, but also justification about why that person might benefit from involvement in a group. And I think that this information is going to be best documented in the clinical impressions box, in that portion towards the end of our evaluations. You're already clicking on the build box phrases that justify our frequency and duration. You're going to need to free type in justification for why they would benefit from being involved in a group. If you're looking for some sample phrases for that, that information is in our group therapy binder introduction page under the group therapy tab under, again, our Arbor Rehab Education website area. And there's going to be some sample justification phrases that you'll need to include in the clinical impression part of the plan of care, along with those CPT codes, so that we can fully justify a person's involvement in a group. And some of those sample phrases are like, patient may benefit from peer-to-peer education, patient may benefit from focusing on a functional task in a distracting environment. And there's a host of different phrases. And I think that you need to individualize those phrases as well, and not just always repeat the same benefit for that person's involvement in a group. Make sure that we're doing individualized care. So make sure you're doing individualized justification for why that group involvement might be appropriate for that individual. Regarding documenting group treatment sessions, again, we need to build a group code 97150 for OT or PT. For speech, that is the billing code 92508. And remember, that is just for cognitive or communication groups. CMS does not feel that dysphagia is appropriate to treat in a group setting. You want to follow the prompts that are provided in a treatment encounter note on the days that you're billing those group codes. So you're going to need to describe the type of group. You're going to want to note the number of participants in that group, and you probably will need to input the number if it is greater than 4. At this particular moment, NetHealth shows that a group can include 2, 3, or 4 participants. We know that for the updates that came out previously, can be up to 6 participants in a group with 1 clinician supervising that group. We want to be sure we document the objectives of the group that will benefit your person. You want to document the skilled interventions that were used during the group. And you want to choose your build phrases carefully, because not all the build phrases are going to be relevant for your discipline. So for example, you might document that the patient participated in a cooking group with 5 other patients to learn how to use a walker safely during a functional activity, and that you instructed them on safe walker navigation around appliances and the use of countertops for stability during functional tasks. It's got it all right there in those 2 sentences. Moving along to discharge and restart documentation, skilled interventions since the last progress note generally are not going to be the same as the skilled interventions that we've provided since the evaluation, because we know that in reality, day 1 of therapy isn't going to be the same as day 20 or 25, whichever it might be. You want to show how treatment's been upgraded or downgraded in the past 10 days. And unless that discharge or restart comes up within 3 or 4 days after the initial progress report, typically we want to show how that therapy has been progressive or in some cases been downgraded to meet their needs. So we want to make sure that we're showing that diversity of care that we're providing. I'm going to talk about some new policies and procedures at this point in time. Our new policy, one of our new policies, is on anti-kickback and gifting policies. So therapists are prohibited from offering, paying, soliciting, or receiving anything of value with the intent to induce or reward referrals. And this applies to all healthcare program businesses, which includes our home health division as well as our outpatient clinic. So as an example, we would not accept a free wheelchair as a reward for referring to ABC Wheelchair Company. A little bit more about gifting from residents and families. Individuals may accept gratuities and gifts of a nominal value from residents only with the approval of the Arbor Rehabilitation Administration. And if a resident or another individual wishes to present a monetary gift, he or she should be referred to that Arbor Rehabilitation Administrator. So I want to define a couple things. Number one, nominal value is defined as $15 for the Office of Inspector General. And your Arbor Rehabilitation Administration would be your FRC and or your regional director or area manager. And you can certainly contact myself as well if you've got concerns. So typically a box of candy, no problem, we can accept that. But if they want to give you, for example, a $50 gift card, that is something you certainly would want to run by your regional director, area manager, myself. We just want to be very clear that we are not really accepting any kind of kickbacks or inducements. When it comes to vendors, we know that sometimes this can be a concern as well. Arbor Rehabilitation employees, they only retain gifts from vendors which have a nominal value. And again, a nominal value is still defined as $15. Arbor Rehab employees will not accept discounts on items or services paid for by Arbor in return for the referrals of other businesses, sometimes called swapping. Arbor employees will not solicit or receive items of value in exchange for providing a supplier or medical provider access to residents' medical records or other information needed to bill Medicare or Medicaid. So if a vendor comes in and says, can you give me a list of names of everybody who has contractors? Number one, it's a HIPAA violation. Number two, it could be a violation of our anti-kickback if he's going to offer you a 50% discount on splints based on giving you a list of names. Furthermore, if you say, yes, I want you to get a wheelchair for this individual, here's their chart and point click care. Once you get the information you need off of it, I need to go see this other person. Again, that is inappropriate because we've now given them access to that person's medical record. It's a HIPAA violation and it's potentially a kickback violation as well. So make sure that we are only providing the information that they need to be able to do their jobs, which they do need, history, diagnoses, Medicare, Medicaid numbers, but we need to be the ones to provide that very specific information. And again, no more than what they absolutely need to have. So moving along, vendors who loan us equipment must have an equipment loan agreement signed as well. And this is a little bit of a new wrinkle for us. We want to be absolutely transparent that we are not accepting gifts. So when the vendor loans us a power wheelchair to trial with somebody, this is when we would want to get this form filled out. Or if it's a communication device, again, any equipment that they're loaning for us for trial, we want to make sure that it does not appear that we're accepting a gift as an inducement for referrals. So it's a very simple, straightforward form, the lender's name, the facility person and contact person's name, the facility address, and then just basically what the equipment is and making it clear that it is only on loan. Okay, we are not involved in anything else with that. Another new policy is for our business associate agreements. And so a HIPAA business associate agreement is a contract between a HIPAA covered entity and a vendor used by that covered entity. So sometimes Arbor is going to be the covered entity and sometimes we're going to be the business associate. When we initiate vendor contact, we are the covered entity. When we call up ABC Wheelchair Company, we're initiating that relationship. We're the covered entity. We need to have ABC Wheelchair Company fill out a business associate agreement before we share any protected health information. But we are also a business associate of the facility. When they initiate a contract with Arbor Rehab, they and we fill out information regarding our business associate agreement with them. So again, all vendors who we contact, who may have access to our PHI of our patients, we need to get a BAA, a business associate agreement, signed off. And we need to keep the original in the facility data binder. We do want a copy also electronically submitted to the corporate office. Just to clarify, when we have somebody coming in to do, for example, calibration on our eSTIM equipment, or then in that individual, and we call up that individual to come in and calibrate our eSTIM, they are not going to have access to PHI. They would not have to have a business associate agreement. If the facility has a contract with Joe's Electronics and Joe's Electronics come in to look at our hot packs and our eSTIM machines, the facility has initiated that contact. It is up to them to have that business associate agreement done with that electronic company. So I hope that that's clear. And again, if you have any questions, feel free to reach out to myself and or your supervisor for any clarifications. Okay, this is our business associate agreement. It's pretty straightforward. Again, this is just a sample of what you should be looking for. All these forms are on our website, and I will be sending this out to your FRC as well, just to kind of get some things started. But in the future, everything is referenced on our website. Our final new policy that we're going to talk about briefly is the Stark Law policy. This is primarily going to apply to our marketers and our outpatient clinic, but just to let you know, we do have a defined policy that will clarify our relationships with our physicians. And again, under our employee portal, we do have all of our policies and procedures updated and alphabetically organized for you, depending if it's a documentation policy, clinical policy, administrative policy, and so forth. So going through a few more updates, we have updated our screening form again to be abundantly transparent about who's responsible for what. So we revised the bottom of this form. It might look a little bit different. We have the data gathered by, which could be any evaluating therapist, supervising therapist. It could also be an assistant. But we do want to have that recommendation then made by that supervising therapist. And that supervising therapist needs to sign off on the screening form. So if a physical therapy assistant does the screening, feels that they might or might not benefit from PT or OT or speech evaluation, they talk with their supervising therapist. The supervising therapist is the one to make that referral to whatever discipline is appropriate, and they sign off. Okay. Again, if you have any questions, do not hesitate to shout out. Another new form, which is not really anything complicated, but it's a paraffin log, kind of like our hydroculator temperature log. You want to remember to keep all the hydroculator and paraffin temperature logs up to date. If they're unplugged, put away in a corner gathering dust, not a problem, the state comes in. But if you're going to roll out the equipment, plug it in, make sure you start these temperature logs so that we can prove to state that things have been cleaned on a routine basis, things have been checked on a routine basis. We know that they are safe to use with our patients. Again, we need to do that daily, just like we do the hydroculator log if we're using paraffin. So changing directions again a little bit, we're going to talk about telehealth. And as of the beginning of August, there's still a lot of unknowns, I guess we'll say, regarding some of the future of our current public health emergency that's going on. So right now, the public health emergency is slated to end in October. And at that point in time, our telehealth options might also end. However, right now on the table, there's a lot of discussion about extending the public health emergency, or there's a lot of conversations about extending the telehealth options even after the public health emergency ends. So right now, we are not exactly sure which way things are going to land. You do want to be sure that every time, even now, every time you do a telehealth assessment, telehealth visit, telehealth discharge, research, that you notify your area manager or regional director so that they're aware of any ongoing telehealth visits and any kind of updates that we have regarding insurances, regarding anything to the public health emergency, telehealth allowances, much less with staffing. Your supervisor needs to be aware, so make sure you've connected with them about that. Regarding our documentation in NetHealth, just as a quick reminder, documents that the clinician or that supervising therapist must complete, whether it's an eval, a research, a Part B progress note, discharge summary, those documents are only to be opened by the clinician responsible for their completion. Remember, as an assistant, if you want to be helpful, open it up, you're going to own a portion of that document. And we cannot prove in the court of law or in any way, shape, or form who owns what piece of that document. So even if all you did was open it, try to be helpful, we can't prove what information you did or didn't contribute to that document. And we are highly at risk of being out of compliance with CMS regulations, licensure laws, so and ARBOR regulations. So just don't do it. If you don't want to own it, don't open the document. Discharge assessments, as I just kind of said, CMS requires the clinician or that evaluating therapist, supervising therapist to complete the discharge assessments. If the clinician or that therapist is unavailable on the last day of treatment for a planned discharge, the following is going to be required. So an FRC needs to schedule the clinician to treat that individual as close to the discharge date as is possible. And during that final visit, the clinician is to document the treatment that they provided and that they're aware of the pending discharge, as well as any kind of discharge destination information that they are aware of, what equipment needs there are, what specific referrals there might need to be made. All that information is to go into that treatment note for their final visit. And that way we have documentation that the clinician was aware of that pending discharge. They do agree with whatever gets documented on that discharge form, that discharge summary. But remember, that summary might be written after that person's gone. And so we want to make sure we've got absolutely transparent information that that clinician is involved and aware of everything related to that person's discharge, equipment, discharge destination, referrals, that type of thing. However, we know that sometimes those discharges come up rather abruptly. And in those situations, the FRCs must communicate this information to the person doing that discharge summary. and instruct that clinician to put a disclaimer in that discharge summary, probably in that recommendations that at the bottom of the discharge summary. And sample wording for that might be, due to patient's sudden discharge from therapy, clinician unable to provide final assessment. So again, that's going to make it very transparent that we're relying on the assistant's notes for that final information. They did not get to do that final assessment as we ordinarily want to do. A couple quick MDS reminders. I know you guys have heard a lot from me lately on section GG, so I'll keep this short but sweet. Remember the definition of each code and select that appropriate code in NetHealth. Use that crosswalk so we don't get a little bit scrambled about contact guard, supervision, setup. All those things can have some different coding. Be careful about that. Remember, if the task was attempted, but they simply could not do it, then that individual is dependent. If the task is not attempted, you want your GG coding to explain why it was not attempted, whether it was for an environmental limitation, safety concern. Remember that if they did not do the task previously and they're not expected to do it in the future, that's the section GG definition of not applicable, which is a little bit different than how it's defined in NetHealth. But remember, only score 9 if it is truly not applicable. They didn't do it before, they're not going to do it in the future. Again, if the person completely refuses the task, then it's a 7. And as you've heard me say before, make sure that you've talked to your colleagues in case they know something that maybe you wouldn't have had the chance to score because the resident refused to do that task. Again, use that crosswalk for accuracy. Remember that each evaluating therapist, each OT or PT, must complete section GG information if the evaluation or discharge occurred within 3 days of their admission date or discharge date, okay? Remember that only 1 goal per discipline is required unless your MDS nurse is requesting some additional goals, but we only have to fill out 1 goal in NetHealth. You will get a little yellow caution sign. You can dash out all the other goal areas. You'll get a caution sign. You can ignore that caution sign. You do need to fill out all of the scoring, but not all of the goals. So I want to make that distinction. And remember that FRCs have the tools that you might need to help facilitate that communication among disciplines or between the assistant to the clinician. That type of information, we do have a form to help facilitate that communication, because sometimes it is tough to look at everything, or people might refuse things that you'd like to assess on that final day. For our speech therapists among us, not to be left out, we're going to touch base briefly on section C. Remember, don't log the person as cognitively impaired on our PDPM worksheet if they've scored 13 or higher on the BIMS. You want to use a secondary cognitive test if their BIMS, again, is 13 or higher, and yet we know that that person has some cognitive limitations or issues. Do quantify, verify, back up your findings with another test, whether it's a MoCA, SLUMS, GDS, any of the cognitive assessments that you're familiar with, to support your reason for picking them up under cognitive impairment. Although for PDPM purposes, they only count as impaired if they score below 13 on the BIMS. Make sure you're carefully following the BIMS scoring and testing criteria, and make sure that you're completing the custom MDS item set forms in NetHealth. If you've not seen this for a while or haven't seen it at all, when you highlight the person's name from your patient list, right-click on their name. At the bottom of the list of options that comes up, you will see custom MDS item set forms. When you click on that, that opens up the field that you see in the screen to the left, and you can complete the information for section C, section K, and that information will get uploaded and shared to your MDS and to your FRC. So with all that being said, and I know there's been a lot, I do want to thank you for your compassion every day, taking such good care of our residents during such difficult times. I do appreciate the integrity of every decision that you make every day, every time that you're interacting with your colleagues and with your patients and with our customers. And absolutely your hard work every day is very much appreciated as well. So please contact your FRC, your area manager, regional director, or the director of clinical compliance with any questions you might have. Again, my name is Cindy Hudson, and my email is cindyh@arborrehab.com. Thank you again. I hope you have a wonderful day.